Peace. Welcome. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. And I'm your moderator and narrator, Uriel Riley. Peace and welcome. Highest heart love. It's time for day 16,888. I'm so grateful and thankful. We begin. Ooh, look at this. Chapter 33. In this 80th reading of Clinical Application of Respiratory Care, Aspiration, Pneumonitis, and Smoke Inhalation. Aspiration, Pneumonitis, Aspiration pneumonitis is a major cause of anesthetic mortality. Most of the contributing factors involved in causing anesthesia or anesthetized and post-anesthetic patients to be at a high risk for aspiration are present in the critically ill. E.g., obtundation, unconsciousness, diminishment of airway protective reflexes. Although the acute respiratory care patient is recognized to be at high risk for aspiration, few data regarding the incidence or impact on morbidity and mortality are available. Suffice it to say that prevention of aspiration and appropriate support for aspiration pneumonitis must be prime requisites in acute respiratory care. Confusion reigns among respiratory care clinicians concerning the definition, clinical course, and preferred treatment of aspiration pneumonitis. The following discussion is designed to provide the respiratory care practitioner with a basis for establishing general rationale for assessment and treatment of aspiration pneumonitis. For further reading, excellent review articles are available. Defining aspiration pneumonitis. Inhalation of pharyngeal contents into the pulmonary tree is defined as aspiration. Inhalation of gastric content is referred to as gastric aspiration. When particulate matter, solid matter, is aspirated, immediate attempts at removal, i.e., the bronchoscopy, are indicated. However, the vast majority of gastric aspiration in critically ill patients involves fluid stomach contents, and therefore The remainder of the discussion will assume the particulate matter has not been aspirated. Inflammation is a generalized tissue reaction to stress from varying agents. Chemical pneumonitis mm, 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 is a pulmonary inflammatory reaction secondary to the stress of noxious substances. Aspiration pneumonitis is most logically defined as chemical pneumonitis resulting from aspiration of fluid gastric content. Pathophysiology of aspiration pneumonitis. The effects of acid insufflation into the tracheobronchial tree were first described in 1920 and have been voluminously studied. The acute inflammatory reaction begins within several hours and increases in severity until a peak is reached between 12 and 36 hours following aspiration. Assuming that bacterial superinfection does not occur, the inflammation decreases to clinical insignificance by 72 hours post aspiration. The primary irritant is hydrogen ion concentration. In dog models, pH above 2.50 causes inflammation similar to that from water aspiration, whereas pH below 2.50 causes severe reactions. Although pH governs the severity of inflammation, it does not alter its time course. Enzymatic actions of gastric contents have little or no effect on the chemical pneumonitis. In man, aspiration of fluid with pH below 1.50 results in chemical pneumonitis all throughout the entire lung. In dogs, aspiration of fluid below 2.5 in volumes greater than zero point 0.4 milliliters over kg will produce reactions at the surface of the lung within 12 to 18 seconds and cause atelectasis at the surface of the lung within 3 minutes. Diagnosis of aspiration. Massive aspiration is rarely difficult to diagnose. However, most cases of aspiration are less than massive and are seldom intimately insulting to the patient. Therefore, the diagnosis must be made by clinical evaluations carried out at the time of suspected aspiration. Regurgitation is the backward flow of fluid in a physiologic system. Vomiting, active regurgitation, involves reverse persistalysis, whereas passive regurgitation occurs without persistalysis and may be caused solely by excess pressure in the stomach. Active vomiting need not be present for aspiration to take place. Much credence must be given to clinical observations made at the time of suspected aspiration. Such occurrences are most often associated with an episode of vomiting or severe coughing, except in the comatose patient, in whom passive regurgitation and silent aspiration are common. Following are general guidelines for clinically evaluating the possibilities of aspiration. 1. The more alert and awake the patient, the more unlikely that aspiration has occurred. The alert patient has intact protective airway reflexes that may cause coughing, breath holding, cyanosis, and extreme distress. These protective mechanisms must never be confused with aspiration. Their presence reduces the likelihood of aspiration. Peace, highest heart love. Thank you so much. Thank you for being here. For the likes and subs, we're pushing towards 600 on this peaceful part of YouTube where we read books and learn from masters. I'm Master Fitness Trainer Uriel Neville Riley. Welcome to this beautiful day. Happy Wednesday. Yes, it's a beautiful day. We have the grocery giveaway today. We have meditation with the great Lorianne Speed today. I had to get the reading in to give you the peace for today. Yeah, the peaceful part of you too. Thank you so much for being here. So, highest heart love. 2. Simple testing of the gag, laryngeal, and tracheal reflexes can provide excellent corroborative evidence in evaluating the probability of aspiration. 3. Top of page 493 in the 33rd chapter. The pH of suspected aspirant should be assessed along with an estimation of the quantity of aspirant. 4. Clinical evidence of acute respiratory distress following suspected aspiration is highly suggestive. However, the absence of respiratory distress does not rule out aspiration. 5. Physical examination of independent lung segments may reveal coarse bronchi. However, their absence does not rule out aspiration. 6. X-ray evidence of localized infiltrate and or atelectasis is in appropriate lung segments is suggestive of aspiration. However, a negative chest film does not rule out aspiration. In summary, the diagnosis of aspiration depends upon clinical evaluation of the suspected event, plus careful physical examination and chest x-ray interpretation. Although positive findings help to make the diagnosis, their absence never rules out the possibility of aspiration. Clinical assessment. The severity of chemical inflammation and the resultant of physiologic stress depend primarily on 3 factors. 1. General patient status. 2. Quantity of aspirant. And 3. Acidity of aspirant. General patient status. The degree of physiologic stress imposed by an inflammatory reaction is greatly dependent on the reserves of the system prior to insult. Obviously, a small degree of chemical pneumonitis may be quite significant in an elderly or deliberated, uh, yeah, debilitated patient, whereas great degree of chemical pneumonitis may be less significant in a young, previously healthy patient. The clinical judgment determining the prognosis of an aspiration partly depends on clinical assessment of the patient's overall status. Quantity of aspirant. Large quantities of aspirant will cause obstruction and mucosal irritation, regardless of pH. The degree of insult caused by non-acid fluid will depend primarily on the amount of aspirin. See near drowning in this chapter. Acidity of the aspirin. A pH below 2.50 will cause widespread chemical pneumonitis throughout the lung, regardless of the volume aspirated. Top of page 494. Much clinical information has been gathered concerning aspiration pneumonia since Mendelssohn first described the clinical syndrome in 1946. The tachycardia, dyspnea, cyanosis, and expiratory bronchi described by Mendelssohn are present with severe aspiration pneumonia. However, more subtle presentation is the rule. Inflammation of the tracheobronchial tree. The parenchymal inflammatory reaction of gastric aspiration ensues within 0 to 5 hours. However, the damage to the pulmonary mucosa occurs on contact. This mucosal irritation may elicit a severe bronchoria, which may be confused with pulmonary edema of cardiac origin. Much of the initial dyspnea and responsive hypoxemia of aspiration pneumonitis is probably secondary to the severe bronchoria and bronchospasms that occurs immediately following aspiration. Dilution or lavage of the aspirated substance is generally considered ineffective and, in fact, may be harmful. Parenchymal effects. Although the aspirant seldom physically reaches the alveolar epithelium, parenchymal reaction is severe when aspirant pH is less than 2.50. Parenchymal effects are primarily those of abnormal alveolar type 2 cells metabolic activity, causing a decrease in surfactant production and rapid interstitial exudation and edema. The resulting decreased compliance is mainly responsible for the increased work of breathing, tachypnea, and refractory hypoxemia of severe aspiration pneumonitis. Hemodynamics. Immediate decreases in systemic blood pressure are common. However, pulmonary wedge pressures and central venous pressure are not elevated. It appears that most of the left heart failure, classically described following aspiration, is, in fact, bronchoria with resultant dyspnea, tachypnea, and rales that mimic heart failure, arterial blood gas abnormalities. Hypoxemia is usually present. Initially, the hypoxemia is secondary to bronchospasms and bronchoria responsive, but eventually becomes secondary to decreased FRC and interstitial edema. Refractory. Hypercarbia is a dire occurrence and necessitates immediate ventilation support. Top of page 495. Treatment of aspiration pneumonitis. Assurance of an adequate airway and proper oxygenation are the hallmarks of supportive therapy, along with proper fluid, electrolyte, and acid base balance. Respiratory therapy. All patients with aspiration pneumonitis require oxygen therapy. The establishment of an artificial airway may be indicated for one, airway protection, 2, bronchial hygiene, 3, airway pressure therapy. Positive pressure ventilation is often necessary, and some evidence exists that PEEP therapy may be beneficial in decreasing morbidity and mortality. Antibiotic therapy. Despite the inability to predict bacterial superinfection or what organisms will be involved, many investigators recommend giving prophylactic antibiotics. At best, the effectiveness of such therapy is doubtful. Retrospective studies have revealed little, if any, decrease in the incidence of bacterial superinfection and a preponderance of gram negative organisms, which often lead to severe necrotizing pneumonitis with sepsis. In general, antibiotic therapy is contraindicated as a prophylactic measure in aspiration pneumonitis. Steroid therapy. Although controversial and without conclusive data, the use of corticosteroids in aspiration pneumonitis appears to be rational if several factors are recognized. One, high doses of steroids administered for less than 48 hours do not appear to result in undesirable effects. Two, severe acid aspiration has a very significant mortality, which no therapeutic regimen has been conclusively documented to alter. Three, no experimental evidence is available to dispute the effectiveness of steroids in acid aspiration of pH fluid above 2.50, a common occurrence in clinical medicine. Four, theoretic considerations of steroid decreasing an inflammatory response are substantial. And five, the administration of steroid anti-inflammatory agents prior to onset of chemical inflammatory process is widely accepted as beneficial. We recommend that dexamethasone the zone, dexamethasone, or decadron may be administered immediately after aspiration. If effective at all, it must be administered in the first 2 hours following aspiration. For the average sized adult, 20 milligrams of dexamethasone should be given by intravenous push as soon as possible following aspiration. This should be followed by 10 mm, 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 milligrams of dexamethasone given intravenously at about 4 to 6 hour intervals for the first 24 to 36 hours. If there is no clinical evidence of chemical pneumonitis at the end of 24 hours, steroid therapy should be discontinued. In all patients in whom there are no complications, steroid therapy is discontinued by 48 hours. Experience has shown that there is no need to taper this short term steroid therapy. Near drowning. Top of page 496. Hi, it's Hard Love. We're in chapter 36 of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. 33rd chapter. Coming to you live from the light here from LA. Got a lot of work to do. So had to come on and get it done, right? Today I'm 16,888 days and soon to be nights on this planet. So what better way to bring it in, right? In peace. Already worked out. Doing my breath work, stretching. Time to read. go outside. It is estimated that over 8,000 deaths occur each year from drowning. Near drowning is the event of water submersion after which the victim arrives at a hospital in a potentially salvageable condition. Approximately 15% of near drowning victims develop intensive laryngeal spasms that prevents water aspiration. Such dry drowning is a true asphyxiation without pulmonary damage. Recovery is excellent if the patient is rescued and treated prior to irreversible hypoxic brain damage. 85% of near drowning victims have significant water aspiration. It is estimated that 90% of these will survive if rescue has occurred prior to hypoxic brain damage and if appropriate therapy is administered. Pathophysiologic events in human near drowning are 1. Hypoxemia, 2. Metabolic acidosis, 3. Minimal changes in electrolytes and hemoglobin, 4. Hypovolemic shock in some saltwater drownings, 5. Pulmonary edema. It must be realized that many near drownings are associated with alcohol or drug ingestion and that gastric aspiration may have occurred. A post immersion syndrome may occur within 24 hours. 1. Respiratory distress. 2. Hypoxemia. 3. Pulmonary edema. 4. Fever. And 5. Leukocytosis. These appear after the patient is initially judged clinically stable and unaffected by the near drowning incident. Near drowning patients must be observed in the hospital for 24 hours. It appears safe to state that all patients who have a normal admission of chest x ray should survive with proper therapy. Fresh water aspiration appears to be of greater consequence than saltwater aspiration, since freshwater appears to directly affect alveolar type 2 cell function. This problem appears to respond to appropriate PEEP therapy. Metabolic acidosis must be vigorously treated with sodium bicarbonate. Hemodynamic monitoring is important in patients with limited cardiovascular reserves. Prophylactic antibiotics and steroid therapy appear to have little, if any, indication or benefit. Carbon monoxide poisoning. Carbon monoxide, CO, is a natural byproduct of red blood cell destruction and normally is attached to about 1% of the available oxygen binding sites of hemoglobin. Carbon monoxide attached to hemoglobin is known as carbon or carboxyhemoglobin. Carbon oxyhemoglobin or CHHCOHB. Heavy cigarette smokers often have greater than 5% carboxyl oxyhemoglobin levels. Heavy exposure to smoke or Auto exhaust may result in carboxyhemoglobin levels well in excess of 25%, a clinical circumstance referred to as carbon monoxide poisoning. Such a diagnosis is made primarily by history of exposure and measurement of COHB levels. Patients typically manifest a cherry red color, tachypnea, and tachycardia. Pathophysiology. Carbon monoxide has an affinity for the hemoglobin molecule that is 200 to 250 times greater than that of oxygen. A carbon monoxide partial pressure of less than 1 millimeter Hg may result in a carb oxide hemoglobin level of 40% or greater. The rate of dissociation of carbon monoxide produces an acute decrease in blood oxygen content that is readily reversed. In addition, high levels of COHB cause the oxyhemoglobin dissociation curve to shift markedly to the left, i.e., the greater the concentration of carb oxyhemoglobin, the greater the hemoglobin affinity for oxygen molecules. In practical terms, this means that tissue will be better oxygenated when 50% of the hemoglobin is absent, anemia, than when 50% of the hemoglobin has carbon monoxide attached. Acute carbon monoxide poisoning may result in varying degrees of brain cell hypoxia. All therapeutic measures must be instituted as soon as possible to minimize the hypoxic effect of CO poisoning. There are no known direct toxic effects of carbon monoxide. Now we know different. Bottom of page 497 of chapter 33. Thank you for being here. Look at that. 3 likes, 3 people here. Hi, it's hard love. Thank you so much. Oh, love you so much. Hi, it's hard love. Respiratory care in the 33rd chapter. Look at that. The alignment. You can't make it up. Primarily, the CO poison patient must be removed from the atmosphere containing the carbon monoxide while airway patency and ventilation are assured. Secondly, the patient must receive 100% oxygen as soon as possible. The high blood oxygen tension will speed the dissociation of carbon monoxide from hemoglobin. In our experience, the COHB level decreases by one half each hour that 100% oxygen is given, as long as the cardiopulmonary system is stable. The increasing oxygen content of arterial blood greatly accelerates the clearance of carbon monoxide from hemoglobin. It is not acceptable to give low concentrations of oxygen while the COHB level is over 20%. When immediately available, the hyperbaric chamber appears appropriate for severe COP poisoning. Smoke inhalation. Exposure to fire and smoke is not an uncommon occurrence in urban areas, and the respiratory care practitioner must be aware of immediate supportive steps. Carbon monoxide exposure must be assumed. There are two concerns in the patient who has been exposed to smoke and heat. One, inhalation of incomplete products of combustion, carbon particles, and toxic fumes, both of which lead to chemical tracheal bronchitis and pneumonia. And two, thermal injury, which leads to mucosal slowing, bronchuria, and pulmonary edema. Carbonaceous inhalation. Carbonaceous inhalation is diagnosed by the presence of carbon particles in the mouth, pharynx, and sputum. The foreign body reaction, in addition to toxic fume inhalation, may lead to a chemical pneumonitis similar to that discussed for aspiration pneumonia. Prime attention must be given to airway patency, ventilation, and oxygenation. Steroid therapy is indicated, along with oxygen and bronchial hygiene therapy. Prophylactic antibiotics are contraindicated. Thermal injury. Bottom of page 498. Immediate concern in thermal injury must be for glottic and laryngeal edema leading to airway obstruction. Tracheostomy is often needed and may be preferable to an endotracheal tube, which may do significant damage to the already traumatized glottis. Pulmonary edema is the most severe sequelae of thermal lung injury and is usually fatal. Supportive care is primarily airway care and airway pressure therapy. We did it. We completed chapter 33 in one read. Thank you so much for being here. What gems, what gems. We have one chapter left. I'll break it up into two readings. Thank you so much for being here, reading with us. Clinical application of respiratory care. And then we've completed another book. The gems flow all over, right? You shake it up on YouTube. We're all weather, all times. I love you so much. One chapter in one read. Yes. Hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. We did it again. We are about to complete another book. Man, I love you so much. You know I love you. Thank you so much. Wow, yeah, it is a big book, right? We did it. Look at that. 498 pages all read. And I will put the vocabulary in the description, be in the playlist. We're on the verge of capitalizing on another read. Thousands of dollars of information crystallizing in our bodies here on YouTube, live from the light. Thank you so much for being here, enjoying the piece. Hope the feed was great and the volume was wonderful. Let's have a glass of love water. I made it. 16,888. So on, so on. I love you. I love you. Mm. I love you so much. I love you. That's how we do it. That's how we do it live from the light. Love to all the light workers, all of my friends and family, all of us. We are the star seeds, live from the light, telling you I love you, all weather. I love you. I love you. I love me. So proud of you. So grateful, thankful for all I have now and all that is coming to me. Highest heart love to the great light worker and wonderful chef and cook, Has Belcher. Highest heart love, King. You are one of the great light workers on this planet. Glassboro's finest. Love to all our friends and family. I love you. Highest heart love. I will see you soon. Peace, peace.